Thank you for checking. Akhila, are you going to introduce speakers, all of them at the beginning, or one by one when they talk?
I mean, I actually thought of introducing them as while they're presenting their topic, but if you want me to introduce them in the beginning, I can do that as well.
I just was thinking you need to put you can stop the sharing and share my screen here. You need to show this.
Okay.
And then this, and then this. Do we need to do that or no?
Yeah, that would be great.
Okay.
How do I access that? I mean, like, would you be?
I can give you access. Let me
or Dr. Humaira will be doing that. Like, how do I do it?
Okay. So can you ask for remote technician? Who wants to do that? I think you will talk about them, right? Akhila?
Sorry, Dr. Nadir?
Okay, I give you the definition so you can, while you talk about them, you can click here, there.
Yeah, I'm able to help you. Thank you.
Dr. Nadir, I think Dr. Doaa Mohammed is not an attendees, is not here.
Okay, let me stop sharing. I will share again. How do I do that? Let's see. Okay. So Doaa.
Yeah, Doaa Mohammed.
Yeah, she's coming. Hello, Doaa.
Yes, I just want to add my pictures. That's why I just leave.
That's fine. How are you?
I'm good. How are you doing?
Very good.
Thank you.
Oh. So we're gonna start in a few minutes. For those who joined as attendees, you're welcome to ask questions. So Akhila, can you ask for the remote control again?
Oh, yeah, sure, Dr. Nadir.
It's all yours now.
Yeah, thank you, Dr. Nadir.
Thank you. Hello everyone. Today we're going to talk about COVID vaccine, and Dr. Akhila will start the webinar. Welcome everyone. Thank you. Akhila.
Good afternoon, everyone. A warm welcome to all of you. I am Akhila Cherukuri, a research fellow of Tele-Geriatric Michigan State University Research Fellowship program. And we are going to talk about COVID-19 vaccine in heart failure and transplant patients today. A brief introduction about the topic would be a transition from the hyperacute phase of the pandemic to the endemic phase was merely possible because of the preventive measures as well as the active vaccination campaigns that were held all over the world. And I'm sure that we come across lots of questions regarding the COVID vaccine during our practice. Like, do we have to take the vaccine? Is the vaccine effective? And what are the contraindications? And what is the efficacy of the vaccine? And etc. So today we are going to address about all these points in our webinar, as well as update you guys about the recent measures to decrease the severity of the COVID-19 infections. Before we start the presentation, let me introduce the speakers and the guests and the cardiology fellows who are a part of this webinar. So our speakers are Dr. Kholood Ahmed, Dr. Humaira Kauser, and Dr. Doaa Mohammed, and Dr. Amna Madni, Dr. Doaa Nasereldin, and Dr. Shaza Alwakeel, and Dr. Naureen Syed. We are all really grateful and thankful to our mentor, Dr. Nadir Abdelrahman, who is the director of Michigan State University Tele-Geriatric Research Fellowship Program. Now let's move on to our beloved guest, who is Dr. Michele P Sartori, who is a renowned cardiologist, intervention cardiologist practicing in Houston with more than 3 decades of experience in this field, who is an associate professor of medicine, University of Houston School of Medicine. And we also have Dr. Joggy George, a young and very efficient heart failure and heart transplant physician who is also a top-notch cardiologist practicing in Houston as a clinical faculty of Texas Vascular and Heart Institute and Baylor College of Medicine. We also have our lovely cardiology fellows who are part of our webinar today. That would be Dr. Lauren Golden, who is an intervention cardiology fellow at Texas Heart Institute, Houston, and Dr. Vishal R Dhulipala, who is an intervention cardiology fellow as well from Mount Sinai Hospital, New York. And we have Dr. Samarth Thakkar, who is a cardiology fellow at Houston Methodist DeBakey Heart Institute. So with that introduction about our guests and our topic, let's move on to our presentation. Our first presentation would be by Dr. Doaa Nasereldin, who will be talking about COVID vaccine types.
Thank you, Dr. Akhila. Good afternoon, everyone. My name is Doaa Nasereldin. Today I'll be presenting on the COVID-19 vaccine currently available in the US. I'll first begin with a brief introduction about the COVID-19 pandemic, which originated in Wuhan, China in December of 2019 and spread worldwide. The coronavirus disease is caused by the SARS-CoV-2 or CoV-2 virus, which is a member of the coronavirus family. It's known to cause respiratory and GI conditions in both animals and humans. And with regards to the structure of the SARS-CoV-2 virus, it has a spiky appearance, as we can see in the picture in the middle. This inspires the name corona, which is a Latin word for crown, as the spikes give the crown-like appearance of the virus exterior. So this spiky exterior of the virus is composed of proteins that aids the virus in binding and invading the healthy cells, initiating the infections. So these same spiky proteins, they facilitate the infections as well. They can be utilized to produce coronavirus vaccines that can stimulate the production of antibodies. and therefore prompting the immune response against the virus. So we know that vaccines are employed in the prevention of the SARS-CoV-2 infection during this pandemic from spreading, and also it helps tame and curb the COVID-19 pandemic. So next slide, we have, we'll talk briefly about the human coronaviruses types. There are about 7 known types. The first human coronavirus was identified in 1960s as of the latest, which is SARS-CoV-2, which is the novel coronavirus during our pandemic, which was previously identified in 2019, like we mentioned before. Next slide, we have, we'll talk about the vaccine candidates in the clinical trials. Now, the COVID-19 vaccines, we have about 222 vaccines that are candidates for clinical trials, and 771 vaccine trials being conducted in 78 countries. Out of those 222 vaccine candidates, we have about 56 vaccines in phase 1 clinical trial, and we have 71 vaccines that are undergoing phase 2 clinical trials, and 85 are on phase 3 clinical trials. As far as we know, we have 40 vaccines that have been approved thus far. Next slide. This will bring us to the main topic of vaccine, which is the vaccine types available here in the US. As far as we know, we have about 4 available vaccines. Pfizer's, Moderna, which both are mRNA vaccines, Novavax, which is the adjuvant recombinant protein vaccine, and Johnson & Johnson, which is adenoviral vector vaccine. We'll discuss briefly in details about each one. Starting with the mRNA, Pfizer. It's approved by the FDA for use in individuals aged 12 and up, and it is also authorized for emergency use for children who range from 6 months to 11 years of age. With regards to the dosages, there are about 4 doses available, 2 of which are primary and 2 of which are boosters, based on the individual's immune status. Regarding if they're elderly or immunocompromised, we can give them a 5th dose that can be administered. Between the first and second primary doses, there are about 4 to 8 weeks interval, while there is about 3 to 4 month interval between the booster doses, 3rd, 4th, and 5th. Next slide. We have the Moderna. It is also an mRNA vaccine that is approved by the FDA. However, unlike Pfizer, it is used for individuals age 18s and up. Moreover, it is authorized also for emergency use for children ranging from 6 months to 17 years of age. Regarding the dosage, Moderna is similar to Pfizer in that there are typically 4 doses available and 2 primary and 2 boosters. A 5th dose can be administered to immunocompromised or elderly individuals as well. And the time interval between the first and second is 4 to 8 weeks, while the booster shots are 3 to 4 month interval. Next, we have the adjuvant recombinant protein. It contains an ingredient known as adjuvant that helps the immune system respond to the spiky protein of the COVID-19 virus. And the Novavax is currently the only available one in the United States to be known as the adjuvant recombinant protein. There are about 2 primary doses that can be given with a 3 to 4 weeks interval in between, and is given to age groups 18 years and older. This vaccine has no booster shots opposite the mRNA vaccines. So finally, we'll talk about the adenoviral vector vaccine available for use in the United States. It contains the engineered virus called the adenoviral vectors that are designed to shuttle a gene from SARS-CoV-2 into our bodies and our cells. So the only one available is Johnson & Johnson, and is currently in the is the only one available here for adenoviral vector vaccine. It can be administered to individuals who are 18 years of age and older as a single dose. There is no booster shots to be given, but we can give mRNA vaccines such as Pfizer and Moderna as a booster shot. I'll also like to know that the mRNA vaccines are typically preferred over the Johnson & Johnson vaccines, given their primary series and booster vaccine. So to sum up, next slide. This is a table to sum up all that we just discussed. And these are the 4 vaccines available here in the United States with the dosages and the age indications for them. So these are some of the references we have used on the next slide. And thank you for your time. I'll now give the stage to my colleague, Dr. Amna Madni, who will be conducting the second part of the webinar. Thank you.
Thank you so much, Dr. Doaa. So our next topic of presentation would be various contraindications to COVID-19 vaccine, which will be presented by Dr. Amna Madni.
Hi, hello everyone. Thank you for attending. I'm gonna talk about contraindication and precaution. First, we talk about type of reaction. We have 3 types of reaction. The first one, immediate allergic reaction, which is defined as any hypersensitivity related sign or symptom, such as urticaria, angioedema, respiratory distress, or anaphylaxis that occur within 4 hours following administration. So the next type is severe allergic reaction. Is possible anaphylaxis, a progressive life-threatening reaction that typically include urticaria, but with other systemic symptoms such as wheezing, difficulty breathing, or low blood pressure, or any angioedema affecting the airway, and diffuse rash, which also involves the mucous surface, like a Stevens-Johnson syndrome. The third type is non-severe allergic reaction, any urticaria beyond the injection site. About next slide, we're gonna talk about contraindication. If the people have history of severe allergic reaction after a previous dose or a component of COVID vaccine, we recommend we do not vaccinate with the same type of COVID vaccine. If a history of non-diagnosed allergy to component of COVID vaccine, we simply avoid the vaccine contains that component. For Janssen vaccine, TTS, thrombotic thrombocytopenic syndrome, following recipient of previous Janssen vaccine, we do not vaccinate with Janssen vaccine. About next slide, we're gonna talk about vaccine, but with precaution. For this category of people, we benefit of vaccination outweighs the risk for most people. And those people history of severe immediate reaction to any type of vaccine other than COVID vaccine or any injectable therapy, like intramuscular or intravenous or subcutaneous vaccine or therapies. People with history of non-severe immediate, like we say 4 hour, allergic reaction after a dose of one type of COVID vaccine have a precaution to same type of COVID vaccine. And people with an allergy-related contraindication to one type of COVID vaccine have a precaution to other type of COVID vaccine. So we're gonna move. We continue in precaution. People have moderate or severe acute illness with or without fever. We defer vaccination until the illness has improved. If there is history of multisystem inflammatory syndrome, vaccination outweighs the risk if clinical recovery has been achieved, including return to normal cardiac function, or has been at least 90 days after the diagnosis of MIS. If there is history of myocarditis or pericarditis after a dose of mRNA or Novavax vaccine, we defer or generally not recommend the COVID vaccine. Observation period following vaccination to monitor for allergic reaction. CDC recommend the following observation period as either 30 minutes or 15 minutes. The 30 minutes for people with contraindication to one type of COVID vaccine who are receiving another type that has been deemed a precaution. For example, people with contraindication to mRNA vaccine who receive Novavax, history of non-severe immediate allergic reaction after a previous dose of COVID vaccine, history of immediate allergic reaction to any severity to non-COVID vaccine, and history of anaphylaxis due to any cause. So for 15 minutes, it's gonna be to all other people. And this is my end my slide. Thank you for your time. I'm gonna give my colleague.
Thank you so much, Dr. Amna. Now, moving on to our next presentation by Dr. Kholood Ahmed. She'll be presenting about the COVID-19 vaccine side effects.
Yes, hello everybody. I'm going to present side effects of COVID vaccine. So I'll start. Okay, can you hear me? I'm going to start with the commonly reported symptoms for the COVID vaccine side effects. They notice that it may make like flu-like symptoms, which like it's a commonly reported symptoms. It's composed of like soreness and fatigue and myalgia and headache and chills and fever. Also, they reported joint pain and muscle spasm and sweating and even dizziness and flushing and feeling unwell every time. And also we have sort of GI symptoms as people reported anorexia and vomiting and some also diarrhea. They also reported like decreased sleep quality, and also they get like every time they think like they had a flu, but actually it's not a flu. And they also get the nasal stuffness and sometimes have tingling. Also, that make me talk about briefly for localized reaction. They just also reported swelling at the site of the injection, and they had itching and like also redness locally. And also reported anaphylaxis started from the simple symptoms like the itchy, as I said, and also like feeling like sneezing and something like that. And sometimes they are reported also with anaphylaxis, which is a severe form that people are getting, like anaphylaxis is a life-threatening allergic reaction. And this most have been reported along with other adverse events of the Pfizer vaccine. This is called like a vaccine adverse event reporting symptoms, like VAERS, that's abbreviation of that. And it's rarely occur after the vaccination, with the onset typically within the minutes to hours of the administration of the vaccine. And also there is most common injection site reaction and delayed large local reactions arising from all vaccine types, like redness and erythema and itching, arterial rash, or of the neck and upper limbs and trunk. And also there's some serious manifestation of morbilliform eruptions. And we are going to talk about that also. Some side effects that's affected the skin. It will be later. I'm just also make a point for like there is the most cutaneous reactions occur in women and middle-aged people after the first dose of the vaccine, with the onset range from the 1 to 21 days after vaccination. In addition, there's cutaneous reactions, and that's all generally self-limiting. and that needed little or even no therapeutic intervention for this one. Okay. So we can go ahead with the second dose for the vaccination because that's, as I mentioned, self-limiting and no other adverse effect of that. Now I can go to the next slide. I'm going to talk about COVID vaccine side effects in pregnancy, which compose of localized reaction. And I will talk also about mild uterine contractions. As we find, there were no significant differences in the rates of side effects according to whether the vaccine was administered during the first or second or third trimester of pregnancy, except of local pain or swelling, which was significantly less common after the first dose when administered during the third trimester, and mild uterine contractions, which were significantly more common after the second dose when administered during the third trimester. The rates of obstetric complications, including uterine contractions or vaginal bleeding or pre-labor rupture of membranes, were very low following the vaccination. Okay, I can go to the next slide, please. I want to talk about some side effects that affected the blood. They reported thrombosis and thrombocytopenia. Here we have cases of thrombosis associated with thrombocytopenia have occurred following the vaccination with AstraZeneca COVID-19 vaccine. The current knowledge of the epidemiologic and pathognomonic mechanism of this syndrome name vaccine-related immune thrombosis and thrombocytopenia, VITT. Thrombosis with thrombocytopenia syndrome, TTS, a rare syndrome, which was characterized by venous or arterial thrombosis and thrombocytopenia. Now I can go for cardiovascular side effects for the vaccine, which contain myocarditis and pericarditis. As we find the relationship between the myocarditis and pericarditis after COVID-19 vaccination has led the belief that the vaccine may act as a trigger of these cardiologic complications. Myocarditis and pericarditis after the COVID-19 vaccine have been reported more in young adult males and most likely to that occur after the second dose of the mRNA vaccine. We have also cases reported after the vaccine, a case of new onset renal limited ANCA-associated vasculitis. Sorry. Okay, and we have also myocarditis, cardiac inflammation that has been reported after Pfizer BioNTech COVID-19 vaccination or Moderna vaccine, particularly after the second dose of the vaccine. These were reviewed together and will thereafter be referred to as messenger RNA COVID-19 vaccination. Now I will go for the COVID vaccine and central nervous system. So we have symptoms here, started with headache, and we have cerebrovascular thrombosis and venous sinus thrombosis. And we have cases of Guillain-Barré syndrome, transverse myelitis. Okay, I will talk about that. Depend on this diagram we have here, as you see, reported case of CVT per million population. Is general population, born for and have Pfizer, and we have Moderna and AstraZeneca and the COVID-19. Now, the most frequent neurological side effects of COVID vaccines are headache, Guillain-Barré syndrome, and venous sinus thrombosis and transverse myelitis. Other neurological side effects occur in much lower frequency. Neurological side effects occur with any of the approved vaccine but venous sinus thrombosis particularly occurs after vaccination with a vector-based vaccine. Next slide. As a continue of the skin manifestations, we have here cases of herpes zoster. Herpes zoster following the mRNA COVID vaccination in patients with autoimmune inflammatory rheumatic diseases were also reported. That's all. These are the references. And thank you so much for listening.
Thank you so much, Dr. Kholood. On a side note, I just want to let all the attendees know that your question and answers would be answered by our guests and our fellow cardiologists at the end of the presentation. And you can please put all your questions in the Q&A box. And moving on to our next topic of presentation, overall efficacy of COVID vaccine, presented by Dr. Shaza Mohammed.
Good afternoon, everybody. My name is Shaza Mohammed. Today, I will talk about the overall efficacy of COVID-19 vaccine. So let's begin. Although COVID-19 vaccine are important strategy for preventing COVID-19 sickness, none of them are 100% effective. And since December 14, 2020, more than 75 million people have received their recommended vaccination. After 1 month from the initial immunization, the level of protection from symptomatic COVID-19 starts to decline. In contrast, a recent study by researchers at Penn State College of Medicine found that immunity against COVID-19 lasts for approximately 6 months. And the researcher compared data from 7 million people who had received vaccination and those who had not. The latter group received doses of COVID-19 vaccination from Pfizer, Moderna, Johnson & Johnson, and the researcher looked at 18 peer-reviewed articles published between December 2019 and November 2021 before the development of Omicron variety that dominated the most recent pandemic wave in US in systematic review and meta-analysis. And more than 577 million doses of COVID-19 vaccine have been given across the country, according to the Center for Disease Control and Prevention. The results show that immunity against COVID-19 infection reduced following complete vaccination, going from 83% after the first month to 22% after 5 or more months. And the result demonstrated that those who received the Moderna vaccine enjoy the highest level of protection. And according to the senior author, Dr. Catherine Pauls, assistant professor in the Department of Medicine, she said it's encouraging to observe that those vaccinated against COVID-19 retain high protection against hospitalization and mortality over time, even as effectiveness against infection waned. So, however, those who received the Johnson & Johnson vaccine have lesser protection, about 74% against severe COVID-19. The study found people 65 and older experience a rapid decline in immunity against COVID-19 regardless of the vaccine they have received. And the researcher emphasized that a number of variables, including the type of vaccine, patient age, newly developing variation, and geographical location, could affect overall the efficacy. I think you omit one slide. Okay, so all done. Thank you.
Thank you so much, Dr. Shaza. Now let's move on to our next topic of presentation, which is the effects of COVID-19 on heart. Will be presented by Dr. Naureen Syed and Dr. Doaa Mohammed.
Good afternoon, everyone. My name is Naureen Syed, and I will be touch basing on the effect of COVID-19 on heart. Next slide, please. So although the COVID-19 is primarily a respiratory or the lung disease, but the heart can also be affected. And the temporary and the lasting damage to the heart tissues can be dual to severe factors. Next slide. The clinical manifestations of COVID-19 can be presented in two ways. It can be asymptomatic and it can be symptomatic. In the asymptomatic, there are no symptoms of heart disease, but on the cardiac testings, that there will be abnormalities will be present, like on the cardiac troponins, they will be elevated, ECG findings will be there, and the cardiac imaging findings will be there. But in the symptomatic group, the patients will be having the symptoms like the palpitations, chest pain, dyspnea. Next slide, please. The cardiac manifestations, the COVID-19 can lead to heart problems among people who never had heart issues earlier. The cardiac manifestations of COVID-19 are more commonly among hospitalized and the critical ill patients. The patients who were admitted to the hospital for COVID-19 had a 20 to 35% incidence of myocardial injury manifested by an increase in troponin. Heart failure in COVID-19 patients may be precipitated by acute illnesses in patients with pre-existing heart diseases manifested by elevated natriuretic peptides. And we have also seen that the cardiogenic shock and cardiac arrhythmias cases among the COVID-19 patients. Next slide. So the cardiac testings that's done includes the biomarkers, electrocardiograms, echocardiography, and the cardiovascular magnetic resonance testings. And in the biomarkers, the cardiac troponin, the natriuretic peptides, they are usually elevated. And the cardiac troponins elevation is a marker of the myocardial injury, and it's the natriuretic peptides, the BNP and the NT-proBNP, they are usually elevated. In the echocardiogram, the usual findings are it's the atrial fibrillation of the flutter, the right bundle block. The echocardiogram, the transthoracic echocardiography findings includes the left ventricular dilatation and the right ventricular dilatation and the right ventricular dysfunction, the left ventricular diastolic dysfunction, and the left ventricular systolic dysfunction. And the usually it's the abnormalities which are present in the cardiovascular magnetic resonance imaging. Next slide, please. So the pathogenesis is usually, of the cardiac injuries in the COVID-19 is complex, with mechanisms that include the viral mediated injury, microvascular dysfunction, thrombosis, cytokines, and the type 2 myocardial infarction. The histological features seen at the autopsy includes the increased macrophages and the cytokine elevation. The cause of injury is likely multifactorial, with evidence of inflammation and manifest by macrophage infiltration, and less commonly by the atypical lymphocytic myocarditis. Next slide, please. So this is a table in which the pathogenesis of the cardiovascular diseases in COVID-19 infections, and these are the cardiovascular effects, which includes the arrhythmia. We have seen that 17% in ICU patients, it's the incidence, and the pathogenesis, as mentioned here, it includes the hypoxia, the angiotensin II mediated electrolyte disturbances, and the systemic hyperinflammation affecting the cardiac ion channels. And it can be due to the drug effects of hydrochloroquine, chloroquine, and antivirals. The myocardial injury includes cardiogenic shock present in 70 to 20% of all COVID-19 affected patients. And the pathogenesis includes the cytokines mediated release of the ROS, nitric oxide, superoxide, ion mediated injury. It can be the systemic hyperinflammation mediated apoptosis of the cardiac cells, direct myocardial cytotoxicities by the SARS-CoV-2 infection, hypoxia, hyperinflammation, and ARDS causing pulmonary hypertension and the right heart failure. We have seen that 2 to 4% incidence of acute coronary syndrome in the COVID-19 patients, and the pathogenesis includes the systemic inflammation and the microvascular dysfunctions caused by the direct cytotoxicity of the COVID-19 vaccine, COVID-19 in organism. And 17% of the patients have also shown that their hypertension secondary to angiotensin II mediated vasoconstrictions and the reduced activity of the angiotensin II, which is anti-inflammatory, antifibrotic, and vasodilatory. 27% thromboembolism cases have been seen in ICU patients and 6% in the wards. And it's usually base cytokines, angiotensin II, and prolonged immobility in critical cases. And the valvular damages and the pericardial diseases are rare and unknown. Next slide, please. So so the other cause we have seen that it's lack of oxygen, as described earlier, as the virus causes inflammation and the fluid fills the air sacs in the lungs, and then the less oxygen can reach to the bloodstream, and the heart has to work harder to pump blood through the body, which can be dangerous in patients with pre-existing heart diseases. The heart can fail from overwork. Insufficient oxygen can cause the cell death and tissue damage to the heart and the other organs. Next slide, please. And so from here, Dr. Doaa will discuss about the cardiac manifestations. Thank you so much.
Thank you, Dr. Naureen. So my name is Doaa Mohammed. I will continue what Dr. Naureen started. And here we'll go through some cardiovascular conditions and what is the news regarding effect of COVID-19 on the heart. So we'll start with myocarditis, which is inflammation of the heart. So COVID-19 may infect and damage the heart directly, as most of the viral infection like flu or influenza, but also can affect the heart indirectly through damage or through the body's own immune system response. Next slide, please. So the other condition is a stress cardiomyopathy. So viral infection causes cardiomyopathy, which is a heart muscle disorder that affect heart ability to pump blood effectively. And this is specifically, we called it dilated cardiomyopathy. And how it occurs when the heart attacked by virus, the body undergoes stress and release of catecholamines, which can lead to stunning of the heart. Once the infection resolves, the stressor ended and the heart will recover. So this can consider it one of the temporal effects of the COVID-19 on the heart. The other conditions, it's arrhythmias and conduction system disease. So patients with COVID-19 may be at increased risk of certain arrhythmias. Factors such as severity of illness and taking specific medication for COVID-19 treatment, so may increase the risk of developing arrhythmias. The vast majority of patients presenting with systemic illness consistent with COVID-19 will not have symptoms, signs of arrhythmias or conduction system. But some patients can suffer, and either can be related to COVID-19 or it can be related to the illness itself. Like patient can be tachycardic with or without palpitation in setting of others illness, as I said, like fever, like shortness of breath, pain. So this all can end it with tachycardia with palpitation. So we have also other clues regarding arrhythmias related to more severe infections and mechanical ventilations. This can be predisposed to atrial fibrillation and other atrial arrhythmias. So the presence of hypoxia, shock, either septic or cardiogenic, or evidence of widespread systemic inflammation can also be predisposed to arrhythmia. Another idea is the presence of electrolyte disturbance like hypokalemia. It can also be a clue. So we have some following observations have been reported from various cohorts like UT prolongation, atrial fibrillation, out of hospital cardiac arrest, in hospital cardiac arrest, ventricular ectopy, and tachycardia and bradyarrhythmias as well. So we have news that most research done recently on August 22 that there is reduced myocardial blood flow is new clue in how COVID-19 is impacting the heart. So summary of this new finding is a patient with better COVID may be twice as likely to have unhealthy endothelial cells that line the inside of the heart and blood vessels. So according to the new published research from Houston Methodist, this finding can be a new clue in understanding the impact of COVID-19 on the heart. So in this study, the researcher found that 20% decrease in the ability of the blood vessel or coronary blood vessel specifically to dilate, and this condition referred to microvascular dysfunction. So dysfunction and inflammation of endothelial cells is a well-known sign of acute COVID-19 infection, but we know little about long-term COVID effect on the heart and vascular system. And this can be one of the next recommendation, that we need more researchers focus on long COVID effects and also on how the strategies, how we diagnose this effect. And this is all for this section. Thank you for listening.
Thank you so much, Dr. Nasir, Dr. Naureen, and Dr. Doaa Mohammed. And now let's move on to our next topic, a presentation, which is efficacy of COVID vaccine and the heart transplant in heart failure patients by Dr. Humaira Kauser.
Hello, everyone. I'm going to take over the webinar right now. So it's going to be basically on efficacy of COVID vaccine in heart transplant and heart failure patients. So coming to the introduction, bronchopulmonary infections are a major trigger of cardiac decompensation and are frequently associated with hospitalizations in patients with heart failure. Vaccination is a key component against coronavirus disease. Solid organ transplant recipients mount a less robust antibody response and to a lesser degree cellular response to vaccines. Heart transplant recipients demonstrate a weaker immune response to the vaccination against COVID-19 compared to the general population. Older age and anti-metabolite agents such as mycophenolate mofetil and vaccinations during the first year following the heart transplant have been indicated as potential determinants of a poor immune response. Looking at the heart failure patients who are hospitalized with COVID-19, what do you expect? They're going to have more of intensive non-invasive and non-invasive respiratory support, more of pharmacological and mechanical circulatory support, longer hospital stay, high risk of severe pneumonia and respiratory failure, more common thromboembolic events, secondary myocardial damage, circulatory decompensation, and also neurological complications and longer ICU stays, and even increased risk of both cardiovascular and non-cardiovascular deaths. Coming to some research studies going on, so basically data from Mount Sinai Healthcare's health systems in New York, United States. They had taken 6,439 patients admitted for COVID-19 with a mean age of 64 years. A history of CHF was associated with 3.6-fold increase in the risk of requiring assisted ventilation and a 1.9-fold increase in the risk of death, regardless of the left ventricular ejection fraction. In a large database in North Carolina, the rate of in-hospital mortality of patients with heart failure hospitalized with COVID-19 was 24.2% when compared to 2.6% and 4.6% in patients hospitalized during the exact same time frame, but for just acute heart failure and some other reasons. Patients with a history of congestive heart failure are prone to heart failure worsening while being affected by COVID-19, which further increases the risk of adverse events within the course of the disease. Coming to more research studies. Moreover, there is no evidence regarding any difference between heart failure with reduced and preserved ejection fraction. There were two separate studies in the journal in heart and lung transplantation, which shed light on post-vaccination immune responses in this specific population after 2 doses of vaccination. So 77 heart transplant recipients who had received the Pfizer vaccine and noted presence of anti-spike IgG antibodies in only 18% of patients at 3 weeks following the second dose. Neutralizing antibody titers were found in just half of those with detectable antibody responses. Due to the weak response after 2 doses of vaccines in solid organ transplant recipients, the possibility of third dose had been suggested, and a recent French study explored the humoral response following this strategy. Looking at the mechanisms underlying the susceptibility of patients with heart failure to develop severe forms of COVID-19, they could include direct myocardial damage, hypoxemia induced by pulmonary involvement, catecholinergic flooding, microthrombi, excessive immune response causing intense inflammation, which results in a significant release of cytokines. Coming to another study, which is basically a systematic review showing immune response to COVID-19 vaccine among the heart transplant recipients. The primary endpoint of the systematic review was to determine a detectable response rate in heart transplant patients. The secondary endpoint of the study was to elaborate on factors associated with a poor immune response. A positive response was variably observed in 0% to 100% of all the recipients. Based on the qualitative appraisal of the included studies, a weaker immune response was implicated in those people who are aged more than 65, male gender, short time interval between the second dose of the vaccine, time of measuring the immune response, vaccination within the first year after heart transplant, and also people who were using anti-metabolite immunosuppressants. Coming to a few other things, so an observational data had established that COVID-19 vaccine is effective at reducing the symptomatic disease, hospitalization, and death from COVID-19. While the detectable serological response is only about 50% in fully vaccinated solid organ transplant recipients, early clinical effectiveness data suggests that less than 1% of fully vaccinated solid organ transplant recipients experience breakthrough infections. American Society of Transplantation recommends that vaccination of patients with heart failure and heart transplant recipients and support a third dose for those who received an mRNA vaccine. It's basically preferred that patients would complete the vaccine series 2 weeks or more prior to transplantation and do not delay. Coming to a few other updated recommendations, they suggest that transplant recipients should wait at least 1 month after transplant surgery to receive the COVID-19 vaccine. However, COVID-19 vaccination should be postponed for at least 3 months following T-cell or B-cell depleting therapies like rituximab, whether given for induction immunosuppression or as treatment for rejection. Another recent joint statement strongly recommends that all solid organ transplant recipients should be vaccinated against COVID-19 to minimize the risks using local approved vaccines, and the booster doses are used in the context of clinical research studies. Meanwhile, continued research taking advantage of all available clinical data and evaluating immunogenicity, clinical efficacy, and exploring strategies to improve vaccine response in vulnerable populations, especially heart transplant patients, which helps us understand and control the COVID-19 pandemic. And these are my references which I've used for my presentation, and I will pass it on to my colleague, Dr. Akhila.
Thank you so much, Dr. Humaira. Well, now that we have known and we have got the answers for most of our questions, let's move on to our next topic, which is measures to increase the efficacy of the COVID vaccine. In spite of all our questions being answered, I still have a question, like, do we need to postpone our heart transplantation or LVAD placement? Well, I think we can answer this question once we dig deep dive into the topic. Let's move on to our next slide. With 40 different kinds of COVID vaccines available, yet we couldn't achieve the 100% efficacy that we actually wanted. That is because of the vaccine efficacy changes over time with emerging where viral strains and other factors like underlying medical conditions and immunity of the host as a whole. And a review article published in New England Journal of Medicine has addressed that vaccine breakthroughs occurred 1 month following the prior immunization. And each vaccine exhibits different potency and duration of efficacy, depending upon, and which depends on the half-life of the neutralizing antibodies produced. On an average, the half-life of the neutralizing antibodies produced would be 60 days, and it would change with different kinds of vaccines. But yet, the evaluation of the efficiency and effectiveness of COVID-19 vaccines is a complex thing due to the lack of the exact pathophysiology of the disease, as well as the diversity of the vaccine formulations and strategies that has been used. And out of all the available vaccines, both mRNA vaccines and adenovirus vector-based vaccine, which is the Janssen vaccine, has induced cellular response, which would last for around 6 months. But the T-cell response induced by the adenovirus vector-based vaccine was found to be high and would last around 8 months. Let's move on to our next slide. So this slide will give us an idea about the severity of the COVID infection. As the severity of the COVID infection increases, the level of the antibody titers decreases. And for any kind of acute viral infection, these neutralizing antibodies would protect the acquisition of the infection, whereas the humoral and the cell-mediated immunity together will help to prevent the progression to the severe disease. Saying that cellular immunity may be particularly important for long-term protection against severe disease for a highly transmissible SARS-CoV virus variants that are newly emerging. And the future study should be done to increase the cellular immunity, not just by inducing the neutralizing antibodies. Let's move on to our next slide. Okay, since we have known that the vaccines induce the neutralizing antibodies, but why don't we have the efficacy? It's because of the evolution of the new viral strains, as well as the host immune responses. And to increase the efficacy of the vaccines, one of the factors is the need of boosters. The CDC advises additional vaccines at times to help improve the immunity and lessen the threat of COVID-19. Given that, till date, only 47% of the available persons in the US have received the boosters. And of these boosters available, there are two kinds of regimens, which is the homologous regimen and the heterologous regimen. A study done based on the reactogenicity and immunogenicity of the heterologous prime boost immunization with COVID-19 vaccine, which was funded by the National Institute of Allergy and Infectious Diseases, has shown that the immunogenicity in the adults who had completed a primary COVID-19 vaccine regimen at least 12 weeks earlier had a safety profile for use of either homologous or heterologous booster vaccines. The same study has also indicated that the heterologous booster regimens have shown that they induced higher amount of immunogenicity. With that being said, the pandemic can be controlled by using these kinds of vaccine regimens and more opportunities to speed up the global vaccination campaign. Moving on to our next slide. Since we've learned about as a whole, like how to improve the efficacy of the vaccines, let's learn about the interventions to improve the efficacy of COVID-19 vaccine in heart failure patients. Vaccination against the COVID-19 in patients with heart failure is needed as early as possible, preferably in an optimal clinical state and optimized treatment of heart failure as well as other comorbid conditions. However, the treatment optimization should not delay the COVID-19 vaccination. We come across many iron deficient patients when we are treating the heart failure. So iron repletion prior to COVID-19 vaccine has the potential to optimize vaccine benefits, was found by most of the studies done recently. With this being said, does the boosters really have improved the efficacy? I think we didn't achieve that state yet. The limitations of the boosters are, the frequent administration, like, you need to get boosters every 4 to 6 months, depending upon your immunological state. And the boosters are not free of the side effects. So I think the studies in the future should concentrate on developing a booster that would last for at least, such that we could reduce the frequency of the boosters from every 4 to 6 months to annually, just like the flu vaccines. Let's move on to our next slide. So I want to address about most common questions that we come across when we're treating the heart failure patients. That is, there are no interactions between any approved vaccines and the medications administered in heart failure patients. So it is essential that as physicians, we make sure our patients take their heart failure medications in spite of they getting their vaccination. And apart from the heart failure medications, the anticoagulants and antiplatelets as well are not a contraindication for vaccination against COVID-19 vaccine. And we definitely have to address about the knowledge on strategies preventing SARS-CoV-2 infection, whether it be vaccination or the preventive measures to improve the mass vaccination campaign and reduce the pandemic. And enhanced community engagement and implementation of research is needed to reduce the misconception about the vaccination. Let's move on to our next slide. Since we've got to learn about the factors, like the factors that could improve the overall efficacy in a general population, as well as in heart failure. So let's talk about the factors that we can use to decrease the severity of COVID-19 infection in heart transplant patients. So a recent study done, which is a pre-exposure prophylaxis with tixagevimab and silagevimab, which is Evishield for COVID-19 patients among 1,112 severely immunocompromised patients, has shown that they had lower infection rates as well as lower severity of the infection among immunocompromised patients. So this is a key to our transplant patients. So the first question that we addressed during the start of my presentation, that is like, do we have to postpone the LVAD placement and heart transplantation? I think we can answer that now. No, we don't have to. We can use the Evishield to increase the potency of the vaccine boosters and also give the timely follow-up and give the boosters as per the recommended timeline. Now let's move on to our next slide. Apart from that, I want to generally address about the adjuvants that are useful to increase the vaccine efficacy as a whole. The recent studies have shown that, the earlier studies have shown that low levels of vitamin D were found in severely infected COVID-19 patients. So studies were done and they found out that one of the recent study, the immunomodulatory function of vitamin D with particular reference to COVID-19 patients, has shown that vitamin D has helped to reduce the pro-inflammatory cytokines and increase the production of antibodies. So it is being used as an adjuvant in COVID-19 vaccination protocol. Now let's move on to our next slide. So here are a few of the references that we have used. And now, since a presentation is done, I just want to let you know, give you some take-home points. So let's move on to our next slide. Since we've heard about all the different kinds of vaccines, currently there are 4 FDA-approved and available COVID-19 vaccines in US and 40 overall vaccines worldwide. Neither heart failure, not common cardiovascular and non-common and non-cardiovascular abnormalities considered contraindications for the vaccination. And the complications outweigh the risk of side effects. So we definitely have to make sure we give the boosters and the vaccinations depending upon the patient's risk and benefits. And the diagnosis of heart failure or any cardiovascular disease itself does not increase the risk of anaphylactic or any other allergic reactions after taking COVID-19 vaccine. According to the studies, vaccinations were found to be 90% effective for up to 6 months against severe COVID-19. And those who received the Moderna vaccine had the luxury to enjoy the highest levels of the protection. Let's move on to our next slide. The COVID-19 can cause cardiovascular issues even among normal individuals. And the symptoms of the coronary artery disease over and above the estimated risk factors is quite relevant in dealing with long COVID. Earlier, myocarditis was one of the most common post-viral effect on the heart, but it is a rare finding right now. And the new clue to the COVID-19 effect on the heart is the microvascular dysfunction. And COVID-19 vaccination is indicated in all patients with heart failure with a compromised immune system, including patients following heart transplantation receiving immunosuppressive therapy. The neutralizing antibodies produced by the vaccines have shown a greater durability than the serum antibody titers, which indicates that vaccines definitely play a role in increased protection against COVID-19 infection. A global preventive strategy, including the vaccines and pre-exposure prophylaxis with monoclonal antibodies and early therapies, might be effective to prevent severe forms of COVID-19 among severely immunocompromised patients. And the further studies should focus on increasing the durability of the neutralizing antibodies to provide long-term protection and be efficacious to all the newer variants. Thank you very much. If you have any questions, kindly post them in the Q&A session. And I would like our guests and our fellow cardiologists, cardiology fellows to add any points that you think is relevant.
So far, there is no questions in the Q&A.
Maybe we can give them another 5 minutes, Dr. Nadir.
Sure.
And in case Dr. George or Dr. Sartori and our beloved cardiology fellows would like to add up to our presentation, any points, that would be really grateful in the meanwhile.
Excellent.
Okay, I see a question that is being asked by Dr. Allison. When should be doing the cardiac follow-up in a patient that got severe COVID, specifically for asymptomatic cardiac patients? So, Dr. George, would you be answering the question? Dr. Nadir, I think we have some difficulty reaching out to Dr. George or the cardiology fellows right now. How about you? Is it okay if you can talk about, like, I've got 2 or 3 questions about a research fellowship program. So would you like to address about it in the meantime?
Sure, yes.
Thank you very much.
You're welcome. So before I do that, maybe you can start or send them the link from the last email I sent you, the link for the panelists, for the cardiologists, the fellows. Akhila?
Yeah, sure,
Please,
Doctor.
thank you.
We'll do that.
Sounds good. So let me talk a little bit about the program or the fellowship that we are currently working on. The program itself is an idea started about 2 or 3 years ago. We got funded 2 years ago, and we started with a few medical graduates, about 16 of them in 2020. And during the COVID period of the pandemic, everyone was literally at home. So we tried to build it on the concept of virtual or telemedicine or telehealth. So the idea is to empower medical graduates who did not match into residency in the US to help them improve their applications by improving their knowledge and skills regarding specifically older adults. As we know, the number of older adults in the US is increasing. So out of all these 16 fellows in the first year, when they completed their program, some of them matched into residency, some went to fellowships, 2 of them went to research fellowship. Second year, almost all of them matched to their residency or other fellowships. So the number of spots, we increased it on the second year from 16 to 50. And with this number, we have a lot of medical graduates who involved in different research projects. So we divide them into teams. Each team has a leader, and then each one is required to have complete project. So they work hard, and we have successful rate of submission and acceptance and presentation in different local, international, and national meetings and conferences. Again, the second batch, some of them matched to the programs of their interest, and some went to other fellowships. The third batch, we invited or we accepted around 120 resident fellows, including some dental graduates and one pharmacist, one therapist in the group. Again, we use different methods for education. We focus on geriatric medicine. We are not excluding other areas, but it depends on the interest of the fellow. And we work on achieving these goals. We also focus on other aspects like clinical skills, presentation skills, teamwork, leadership skills, organization skills, presentation skills, and we will focus also on interview skills. All this will be done virtually. So if there are other questions, let me know. The next opening for new batch will be in April 2023. Thank you.
Okay, so our next question I see is, based on the COVID-19 recent studies, which vaccine has the highest efficacy after the booster vaccine dose? And I would say that, Dr. Nadir, can I answer that or?
Yes, please go ahead.
Yeah, studies have shown that Moderna has an edge over the rest of the vaccines to provide higher efficacy that, among the booster vaccines. And out of all, the heterologous vaccine regimens played a very important role. So the mix and match is always best. That is what the studies have shown. And if you specifically want me to answer one particular vaccine, that would be Moderna. I think I've answered that question. So we have another question regarding the fellowship, which is how and where do we apply for fellowship and what are the requirements?
So the requirement, hopefully you are interested in applying for residency, so you passed your USMLE, that's step 1 and 2. And if you are interested in doing some research work, so you will see, send us your CV. If you have applied in the past to UAS, you can send a copy of your application along with your current CV and a photo. We will review all the applications, and then you will be notified if you've been accepted, and we'll take it from there. To apply, we have a website where you can apply to the program. It's going to be shared in the QR, and you can do that. I don't think they will see the chat, so let me just share the website. So it's going to be Geriatric Geriatric Fellowship.glideapp.io. So you log into this system and you apply, and it's a form. You can complete the form and upload your documents. Thank you.
Okay, can you please share the screen once again, Dr. Nadir, with the website?
Yes.
I guess some people did not catch the website.
So Geriatric Fellowship.glideapp.io.
So we have another question. Should one complete residencies to join geriatric fellowship?
So this is a research-based online version of fellowship. So you don't need to do a residency. Hopefully the goal is to help you get into residency. It will help you in your application, and hopefully it will help your skills when you see patients when you are around at the hospital or outpatient. So no, not necessary to complete economic and family. If you are going for fellowships that are clinical, other than our program, they require that you finish either internal medicine or family medicine. Most of the programs are 1 year. Some of them will be 2 years, including 1 year in research. Thank you. The duration is 1 year, but some of the fellows may extend that. It depends on their availability, and if they want to extend, we are also will be happy to help them. It's a free program. The first 2 years were covered for the expenses of the fellowship by a grant from MSU. Currently, we are seeking additional grants. So you will not be paid, neither you will pay for the program. So it's free for you guys. And it's at this time, it's volunteer work from our faculty here at MSU, Michele P, and along other attendants from other institutions who try to help us. Thank you. So after completing your, let's say, first year, and you finish the requirement, which is at least you finish 1 research project, the more the better, and you will receive a certificate of completion. And hopefully by that time you will enjoy joining a residency program if this is what you want, or another fellowship. Thank you. Unfortunately, we don't offer clinical training or services. It's a virtual research program. The skills that we offer are virtual, including interview skills, communication skills, leadership, etc. So there is one question for the panelists about the vaccine. Anyone wants to answer that question?
I'm sorry that our guests or the cardiology fellows are busy right now, so they are not able to, do the Q&A session. But I think I can, to my best knowledge, I would like to address the question asked by Dr. Allison, which is when should be the cardiac follow-up done in a patient that got severe COVID infection? Well, based on the studies, there is no hard fast rule that it has to be done at this particular period of time or point of time, but as early as possible is the best. And the recent studies have shown that within the first 30 days after infection is the best time. And the follow-up should be done for the rest of, at least for a year after the infection, for sure. So, yeah. Do we have any other questions? So we have intervention cardiology fellow. I think he would be the right person about the question that we have. Hi, Dr. Dhulipala. Thank you for attending the webinar in spite of your busy schedule, and sorry to pull you out of the your cath lab. And we have a question by Dr. Allison, which is, when should we be doing the cardiac follow-up in a patient that got severe COVID infection? Specifically, that would be, she's asking for asymptomatic cardiac patients. When should the cardiac follow-up be done who has got a severe COVID infection?
Hi, everyone. Thank you for everyone it looks like a big audience. Thank you for bringing me. I'm Michelle, by the way. Nice meeting you all. Just want to get the question right. So if someone has a severe COVID infection and asymptomatic cardiac-wise, apart from the COVID or shortness of breath, asymptomatic cardiac-wise, when they had the severe COVID infection, they didn't have any pericardial or myocardial damage, they didn't leak any troponin, and they didn't have any symptoms, and their excess tolerance after the severe COVID infection was good, then I am very less concerned about their cardiac status. Because let's say for someone like you or me, or like middle-aged or like a little older, 40s, 50s, anyone, when we have a stress test, we stress the heart to see like if there's anything that can show up, like if there's an ischemia or any wall motion, or if there's any cardiac problem that shows up. Like severe COVID infection by itself is a stress test for a patient, I would think so. And then, so if someone didn't have any cardiac problems or symptoms or any cardiac biomarker, troponin, or any problems of that sort during the severe COVID infection, I'm not concerned about their heart as much. Does that answer the question? Can you guys hear me, or did you not hear me?
Yeah, we could hear you.
Oh, okay. Okay.
Thank you for your answer. And I think that has answered Dr. Allison's question. Thank you so much. And we have another question. Are booster vaccines really required? And what would happen if one would not take a booster vaccine in general? I think that was asked in general. But if you could also specify about, especially in cardiovascular patients, that would be really grateful.
Yeah, in general, I do believe in booster. I think whatever the data shows, it works. But then specifically for the meeting perspective, if you see for heart failure population, I think it does work because there was, I only read like 1 or 2 studies for COVID vaccination heart failure. One was from Denmark that was presented like last minute ESC. I don't remember the stats, but then there's one more in Journal of Cardiac Failure, I think that's published in the last 2 months by Dr. Lala from Mount Sinai. And like on retrospectively, when they looked at 1,000 patients, the people who did get booster did better in terms of heart failure admissions and mortality than compared to the people who did not get the booster. So there's a clear difference between unvaccinated, partially vaccinated, completely vaccinated, and completely vaccinated plus boosted. So all the 4 arms have their statistically significant differences between outcomes. So there does lie a difference between with booster and without booster in heart failure. I'm not sure if there's any prospective studies, but that's something for you can look up maybe.
Yeah, sure. Thank you so much, Dr. Vishal, for answering that question. Do we have any other questions?
All right.
Thank you so much.
Yeah, I
thank
think
you so much for
questions. Thank you so much, Dr. Vishal. Yeah, I'm sorry to cut you on, Dr. Nadir. Go ahead.
No, that's okay. I just want to repeat the same. I'd like to thank you so much for your help and attending and answering the questions there. We really appreciate your time and your knowledge. Thank you.
Thank you so much, guys. Good luck with everything. Feel free to reach out if you need anything, okay?
Appreciate it.
Thank you.
Right, take care. Good luck.
Do you have more questions?
Yeah. Do we have any more questions? I think we have one question regarding how many applicants do you take per session? Like, did we answer that question? No, I think we don't have any more questions. If I'm not wrong, we don't have any more questions, at least regarding the webinar. Maybe a few questions regarding the regarding our fellowship program.
All right, we have a couple of minutes and we can complete the webinar. Any last comments from any of the panelists before you finish? I'd like to thank all the attendees, all the panelists, all the speakers, and I'd like to thank the fellow and the host and the guest and cardiology fellows who help us get this up and running. Thank you so much, everyone. And if there is no more questions, I leave it for Akhila to close this webinar. Thank you.
Okay, we have got one more question. Is step 1 required for research per session?
Yeah.
Okay, I hope Dr. Zarek, your question is being answered. So with that being said, I want to thank each and every one of you who had attended our webinar and making our day. And I want to thank Dr. Nadir, who has mentored us all through this process and made this possible. And I want to thank all my teammates who really helped me to host this webinar. Without their help, I wouldn't be able to do this. And I want to on a special note, I want to thank all the guests, Dr. Sartori and Dr. George, and our beloved cardiology fellows, and Dr. Lauren, Dr. Vishal, and Dr. Samarth. Especially, I want to thank Dr. Vishal, who was able to come out of his cath lab and answer the few questions that we had and shed insight about the recent studies and all that. So I'm very much happy, and I want to thank each and every one of you for making this possible. Thank you so much.
Thank you. Have a wonderful day, and wherever you are, have a wonderful night if you are at night there. Thank you, and hopefully we'll see you next webinar.
Thank you so much.
Thank you so much.
Thank you so much, Dr.
Everybody.
Thank you. Have a nice day. Bye-bye.
Thank you. Bye-bye.